The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon or good morning, depending on where you are. My name is Deanna Hellshire. I'm director of the Michael and Susan Dell Center for Healthy Living at the University of Texas School of Public Health, and I'd like to welcome you to the first of a series of webinars on results and tools from the Childhood Obesity Research Demonstration CORD 1.0 projects. So today we're going to be talking about activities in the healthcare setting for primary prevention of childhood obesity. We're really excited to have y'all here. We have a lot of interesting results to share with you and are looking forward to your questions too. So as we move through the webinar, please feel free to enter your questions on the chat line, and we will get to them at the end of all the presentations. So today we're going to have a brief introduction and then 3 presentations. So the first introduction will be by Heidi Blank, who is Chief of the Obesity Prevention and Control Branch, the Division of Nutrition, Physical Activity, and Obesity at the National Center for Chronic Disease Prevention and Health Promotion at CDC. She is joined by Carrie Doyema, who is a behavioral scientist there in the Division of Nutrition, Physical Activity, and Obesity at CDC. So they'll both be giving an overview of the CORD project. Then we will talk about each of the individual site-level CORD projects. Dr. Elsie Taveras, who is Chief of the Division of Academic Pediatrics at Massachusetts General Hospital for Children and Professor of Pediatrics at Harvard Medical School, will give the first presentation. The second presentation will be Dr. Sarah Barlow, who is Professor of Pediatrics in the Department of Clinical Sciences at UT Southwestern Medical Center. And the last presentation will be Guadalupe Ayala, who is Professor and Associate Director for Research in the Division of Health Promotion and Behavioral Sciences at San Diego State University. So I know you'll enjoy these presentations, and Dr. Blank, I will move it over to you.
Thank you very much, Deanna. Welcome, everyone. I thought it would be helpful to give an overview of the Childhood Obesity Research Demonstration Project, which we call here at CDC the CORD 1.0 project. I'd like to acknowledge the CORD team that put a lot of support and time into these really exciting projects, including Carrie Doyema, Brooke Belay, Allie Goodman, Megan Harrison, and Suzanne Garner. Next slide. So here at the CDC in our Division of Nutrition, Physical Activity, and Obesity, we work on supporting all Americans across the lifespan. I won't go into detail, but you can see here there's much work that we do in supporting states and local grantees in getting a healthy start, having our children grow up strong and healthy, maintaining good nutrition, and keeping active. And within each of these areas, you can see the types of evidence-based strategies and approaches that we really work with researchers, public health practitioners, and other organizations to keep our nation's health at its best. Today, I'm going to focus mostly on the childhood obesity managed perspective. Next slide. So, as many of you know who are attending this webinar, childhood obesity is having a dramatic effect on Americans' health. We have over 14.5% of low-income children who are in the WIC population having obesity. From our National Health and Nutrition Examination Survey, we know about 17.5% of children aged 6 to 11 have obesity, and almost 6% of those have severe obesity. Obesity can have immediate effects, including mental and physical health problems, but it also tracks into adulthood. Currently, about 1 in 4 young adults are unfit or too heavy to actually serve in our military, which also puts our nation at risk for security issues. And from a payer's perspective, adult obesity costs an estimated $147 to $190 billion per year in medical costs. Next slide. So we also know that we're not without tools. We do have a set of childhood obesity recommendations that have been coming out over the last number of years. So the National Academies of Medicine, also in prior called the Institute of Medicine, recommended taking action in multiple settings where children live, learn, and play. This includes child cares, schools, pediatrician offices, and the community at large. We also had the American Academy of Pediatrics practice guidelines for childhood obesity, which included screening for children 2 years and older, as well as best practices around counseling and program initiatives to help support young children struggling with obesity. And then in 2010 and again in 2017, we had the U.S. Preventative Services Task Force report recommending that providers screen children aged 6 years and older for obesity and providing or referring them to intensive lifestyle modification programs. Next slide. So in 2009, as part of the Children's Health Insurance Program Reauthorization Act, or CHIPRA, a program was designed that was a multi-sector approach to look at both prevention and treatment of childhood obesity. In 2010, through the ACA, funding was allocated to CMS and then to CDC to actually conduct a research project to look at the best ways to really reduce obesity among low-income children eligible for the CHIP and Medicaid population. So the CDC put forward a funding opportunity announcement and funded 3 grantees: the University of Texas Health Sciences Center at Houston, San Diego State University, and the Massachusetts State Department of Public Health. And these initiatives were to include multiple settings, multiple levels, to really focus on behavioral management. This included increasing children's physical activity, fruits and vegetables and healthier beverages, ensuring adequate sleep, and decreasing energy-dense types of foods and drinks, as well as screen time. So really looking at the behaviors related to obesity. As I mentioned, the target population for these research demonstrations were low-income children, and it was really to inform the future of CHIP and Medicaid policy related to increasing opportunities for obesity prevention and treatment. Next slide. So this is just a schematic that was created as part of CORD, and this is what I've talked about being multi-setting or multi-sectoral, that really we're using best strategies for obesity promotion from prior research in the healthcare, ECE, school, community. And we also wanted to make systems change, building upon the assets of a community and their strengths, but also providing extra education and support to really think about the social ecological approach to ensuring that we have healthy children. And the outputs really are the tools, peer-reviewed manuscripts, and other lessons learned that can help stakeholders, policymakers, and others really benefit low-income children in the U.S. Next slide. So as the webinars proceed, we'll talk quite a bit about the collective approach that was used in CORD 1.0. We're going to talk a little bit about the role of community engagement and community coalitions, the linkages that were formed between clinics, communities, and other organizations, and again, how we were implementing best practices, but also finding novel ways to ensure uptake of strategies as well as collaboration among key organizations. In the healthcare setting, we'll talk more and we'll learn more here about how to offer the best quality care for families, including screening, counseling, and the use of electronic health records. And another part of CORD that was important was the inclusion of community health workers to really aid in the recruitment, retention, and delivery of interventions. A big part of these grants were really to think about building upon the state, the community, and organizational capacity, understanding the types of resources needed to deliver these interventions in low-resourced organizations. And this included looking at optimizing cost and understanding the best TA models. Through the research part of this project, we have both process or implementation outcomes, as well as weight and other behavior outcomes. And again, really to help us inform other CDC grantees, as well as sister agencies and CMS and other payers. Next slide. So I do want to highlight that outside of this webinar, we're very happy to have 2 websites on the CD site that has over 21 publications that have come from the CORD project, as well as information that we have related to the sustainability efforts, as well as a new project called CORD 2.0. And with that, we'll go on to the next speaker. Thank you.
Good morning, good afternoon, everybody. My name is Guadalupe Suchi-Ayala. I'm with the California CORD Project. Next slide. California CORD was a partnership between San Diego State University and our research institute, the Institute for Behavioral and Community Health, Clínicas de Salud del Pueblo, which is a federally qualified health center with about 12 clinical sites, and the Imperial County Public Health Department, which is a public health department. The reason why we decided to work in Imperial County was because of the significant childhood obesity rates, which at last estimate were approximately 40%. Next slide. The objectives of California Core, the research objectives were to test combined and independent effects of healthcare and public health intervention approaches to prevent and control childhood obesity among children 2 to 12 living in Imperial County. But our really practical objective was to try and test a whole community approach to support engagement of healthy lifestyle behaviors among these kids and families. Next slide. Here's our study design. I'm going to focus specifically on the healthcare component. If you could click the slide. As well, and we'll specifically be talking about the effects across the healthcare condition. Next slide. Next slide. The healthcare component included 5 changes: policy changes, staff changes, provider trainings, electronic health record changes, and a family wellness program. We essentially were trying to capture the obesity care model and implement this in the federally qualified health centers in 3 of their clinics to see if we could create a system of change that would impact these families. Next slide. It was important for Clínicas de Salud del Pueblo, the federally qualified health center that implemented this intervention, to institute first policy changes. The policy changes were really as a way to incentivize follow through on some of the recommendations. So ensuring that when the quality people were checking the medical records, they were making sure that the providers were following through on the changes that the system wanted to institute. Next slide. Although Clínicas has a very strong outreach department, because one of our objectives was both a combination of in-reach and outreach, we hired a cadre of community health workers and a coordinator to implement this effort. In addition, we hired a patient care coordinator to serve as a bridge between the 3 clinics and the community health workers. Next slide. We instituted 5 provider trainings. These were primarily trying to reach the physicians, but also some of the nurse practitioners and medical assistants. You can see on the slide the various topics that we presented. Individuals who gave the trainings, a variety of different individuals, including Sheila Gahagan, who's the Chief of Pediatrics at the University of California, San Diego. In total, we had 30 providers complete all 5 trainings. Next slide. In terms of electronic health record changes, we initially had challenges with modifying NextGen, primarily challenges with getting our changes overridden, which was a good lesson to learn very quickly. We then learned how to use NextGen more effectively and made the modified changes to include alerts to flag for BMI in the overweight or obese range, as well as developing a 4-point patient treatment plan that included healthy lifestyle plan and goal setting activities and referrals for additional lab tests, special services, as well as a family wellness program. Next slide. As you can see here, the electronic health records included opportunities for alerts, for writing detailed provider notes, and for referral services. Next slide. These all, one more slide. These all then informed a treatment plan, which was reviewed with the healthcare provider along with the patient care coordinator. And then the family and child received a care plan as they exited the visit. Next slide. Here's a snapshot of implementation at one point in time. If you look at the middle column, we had good to moderate use of the cord EHR features. And then we had moderate reach in terms of getting referred to the community health worker and then ultimately referral to the family wellness program. Next slide. So the family wellness program was a series of activities that we implemented. It built off a previous evidence-based intervention that was funded actually by the American Cancer Society, in which we had good outcomes. So we adapted this intervention for the Family Wellness Program at this clinic to include a series of workshops as well as opportunities to stay engaged with the families through motivational phone calls, newsletters, and an annual booster event. As Dr. Blanc mentioned, this is one of the toolkits that's available for others to use. We're just completing some of the materials. The toolkit is available in English and Spanish and includes training materials for the community health workers, as well as all the materials for the Family Wellness Program sessions. Next slide. In terms of understanding attendance in the Family Wellness Program, as most of you know, if you've been working in this field, engaging families, particularly around the issue of obesity, is somewhat challenging, especially with low resource communities where they may have a lot of competing factors. Two of the things that we found, and this is based on work by Emily Schmid, who was a doctoral student with us on this project, finding that those families who were receiving food assistance, whether it was WIC or EBT, were more likely to engage in the intervention, so less likely to non-attendance, and those who were more ready to change were less likely to be non-attendant. So essentially, if they were ready to change, they were there, they were with us, they were engaged, as well as if they were on some sort of food assistance program. Next slide. I think what was most interesting from this work that Emily did was really understanding qualitatively barriers and facilitators to attendance. And one of the unique things that we found was that parents who attended more workshops believed that their child would benefit from the parents actually increasing their knowledge and skills. So as you can see from this quote, as a mom, I think I thought about it. I thought about them, the kids, about how to form good habits, how to be a better mom, just to be a better guide for them. Parents who, on the other hand, parents who attended fewer workshops believe their child would benefit more directly through health improvements. As illustrated in this quote, I decided to join because my daughter, she was told she was pre-diabetic. That's why, in fact, that's why they referred us to Our Choice, because her insulin level was high. Next slide. We have an evaluation cohort in which we're evaluating the changes. We recruited 1,186 children nested within 848 households. And you can see some of the demographic characteristics there. Not uncommon to our previous studies, we had an 84% retention at the 12-month follow-up appointment. Next slide. Here's just a bit of evidence regarding what we've seen so far in terms of changes. So looking at the various ways in which BMI has been examined among children, we did see that those who were not in the healthcare condition, so those who did not receive the healthcare condition, had higher adjusted raw scores or higher BMI for the 95th percentile at follow-up. We saw no condition effects using BMI Z-score or BMI percentile. We also examined the intervention on quality of life, both using the PEDS QL, looking at psychosocial and physical quality of life, and found no condition effect for the healthcare condition. We did see some changes in diet where there was a reduction in calorie and food intake, more drinking of water, but we saw no effects on sugar or fruit and vegetable intake. We also saw no condition effects on TV watching, video games, or days being active, but we did see an increase in hours of sleep. Next slide. Some of the lessons learned we had from this project is obviously provider engagement is critical for implementation. If we would do one thing differently, although we had good provider attendance, we would have offered some continuing education credit, and that's what we're doing now in a different study. As I mentioned earlier, the EHR changes needed to really be made in collaboration with a software company in order for them to be sustained. And one of the things that we had wanted to offer was more dietary assessment and treatment, and we were unable to find a registered dietitian to hire for this project. So trying to make more calls for specialty care in rural communities. In terms of attendance in the Family Wellness Program, We are really looking at that data very closely. We found that the implementation of the Family Wellness Program was not implemented always as planned, but that was not necessarily a bad thing. We found that the community health workers were really engaged at trying to motivate them to attend and really using a variety of different strategies. Next slide. I just want to acknowledge all of my wonderful collaborators and thank you for joining us this afternoon or morning. Next slide.
Elsie, are you on mute?
Hello? Sorry, I think I had unintentionally muted myself. Hi everyone, I'm Elsie Tavares. I am, as Deanna mentioned, here in Massachusetts, and I'm presenting on behalf of our team about the Massachusetts Childhood Obesity Research Demonstration Project that we call MassCord, and sometimes also called Mass in Motion Kids. Next slide. What I'm going to present today is a little bit of both, actually, the primary and secondary prevention strategies that we used in MassCord. But before I do that, similar to what Dr. Ayala presented and Dr. Blank presented, what we set out to do was to develop a whole of community intervention to prevent and manage obesity among children 2 to 12 years of age. And similar across all of the CORD projects, our objectives were to implement evidence-informed programs to prevent obesity among low-income children across multiple sectors and levels. In our case, we did this in 2 Massachusetts communities, very low-income Massachusetts communities. And the second objective was to develop sustainable partnerships across clinical and community settings that would essentially outlive the research funding that provided a bolus for establishing these partnerships through CORD. Next slide. So to give you a kind of eagle eye picture of what implementation of CORD looked like here in Massachusetts, and to describe a bit the sectors and levels, I'll show you this image that describes where we were intervening. Primary care is what we'll focus on today. In future webinars, we'll talk a little bit more about our interventions in the WIC program, in childcare settings, in schools and after schools, and in community-based settings through coalitions. In each of those sectors, we had interventions that reached directly individuals and families that were more at a systems level and that extended outside of our various systems to communities and community level activities. Next slide. So what we implemented in MassCord in the federally qualified community health centers in 2 communities is essentially a package that we've been working on and iterating for over a decade here in our research labs, and some of our work both through MassCord and in our previous interventions, including the STAR intervention and the Connect for Health intervention. And what we've been doing for quite some time is trying to get a sense of what is the package for intervening on childhood obesity prevention and management that can be implemented in the primary care setting. And what we implemented in MassCord was the following package. Our components included computerized point of care decision alerts in the electronic medical records, which I'll talk a little bit about. We also, similar to what Dr. Ayala presented, provided advanced training to both clinicians and staff in the primary care settings. In addition to what we did to support primary prevention and management of children who are coming in for primary care, we also established in both of the community health centers a freestanding healthy weight clinic to support the more extensive pediatric weight management in these two settings. We had community health workers who were the primary liaisons supporting care extending outside of the clinical setting back to community-based institutions and organizations. And then we implemented a number of environmental changes such as signage and other changes that we made to the clinical setting to improve the healthfulness of the health centers. Next slide. So the very first tool that we implemented was an electronic decision support tool. There are many different examples of these tools. We have a number of them that we've developed for NextGen, for eClinicalWorks, for Epic, and I'll show you a couple of examples of the ones we've developed in Epic. But the main idea of these tools is to provide a flagging system via a pop-up alert or some sort of alert to make clinicians aware at the point of care when a patient is coming in who has a body mass index greater than the 85th percentile. So a flagging ability so that we basically make flagging and detection and awareness of children with an elevated BMI a universal aspect of all primary care visits. The second thing, in addition to the flagging process, is the ability to provide clinicians with a structured template or note to guide weight management. And so being able to put at the point of care for clinicians the best knowledge and evidence we know about how to provide weight management for their patients. And so what that has included in many of our electronic health record support tools is the ability to know what are the laboratory orders for comorbidity evaluation among children with obesity, the ability to document and code for obesity-related diagnoses and counseling, including the documentation of HEDIS codes. We provide in our tools referrals to healthy weight clinics and other referrals in some of our other programs to nutrition services and other services for weight management support. And then we provide structured goal setting, questions and tracking to inform what each visit, including that first visit, will include. Next slide. I'm going to show you just a couple of examples of what these tools tend to look like. This is actually some tools that we developed for our Connect for Health study that were developed for Epic. But basically what we've created is the ability to create a neon yellow hard stop to the clinical workflow that is triggered if a child comes to their primary care visit and at that day's height and weight measurement has a body mass index that is over the 85th percentile. So the clinician has a hard stop in their clinical workflow that to allow them to be triggered to the child at that visit having an elevated BMI. What that tool allows is also the ability to open, in Epic terms, a smart set, the structured note that will take providers through a structured approach to the care and management of children at that day's visit. Next slide. As I mentioned, in addition to the flagging, we have created the tools to be able to standardize the approach to weight management within the primary care visit. And in Epic terms, these are called smart sets. We've gone through several iterations of these to be able to combine what a smart set would look like, both for a primary care visit but also for a primary care visit for a child with obesity, which was one of the biggest criticism of these tools in the past, is that there were too many smart sets or different kind of structured nodes to go to, rather than having them all be kind of one-stop shopping for taking care of these patients. Next slide. We collaborated with the National Institute for Child Healthcare Quality to provide advanced training for the clinicians in the federally qualified community health centers and the surrounding pediatric practices. And those topics included current obesity prevention and treatment practice, quality improvement science techniques, modified motivational interviewing techniques. And the way we structured that, those trainings was a one-day learning session, regular monthly check-ins, and then on-demand supports through previously kind of archived presentations and direct coaching to the clinicians on site for being able to implement some of the tools that we were developing. Next slide. The other thing that we did in the 2 community health centers was to create within the health centers a freestanding healthy weight clinic. And I won't have too much time to go through this in detail, but essentially these clinics included a provider, a clinician, most of the time a MD or a nurse practitioner, a nutritionist, and a community health worker that would meet with patients and their families twice a month for 6 months. The patients were referred to the clinic from the primary care providers within the federally qualified community health centers, and it followed the next steps guide that you'll hear a little bit about in Dr. Barlow's talk, and also developed by NICHQ. Some of the benefits, obviously, of having a healthy weight clinic on site is the increased efficiency, the decrease in no-show rate. It prevents hospital referrals. It provides a medical home, or provides pediatric weight management within the patient's medical home, rather than having, in some cases, to refer patients out to subspecialty services outside of the clinic. Next slide. We also hired for each of the community health centers community health workers who, again, were the liaisons working with the healthy weight clinics and the primary care sites to directly support children and families when they sought their care at the clinic, but also who were wellness navigators. They connected families to community resources, they engaged with other community organizations to build those connections, and they also assisted in making the environmental changes to improve the health of the community health centers. Next slide. By design, our intervention sample were predominantly very low income families who received their care in the community health centers in the 2 towns and in the 2 communities that we worked in. We had 2 intervention communities and 1 comparison community. And while there were a few differences in racial, ethnic background of the population, the per capita income across these 3 sites was about $20,000. Next slide. So our main result, what we found, when we looked at change in BMI Z-score for all of the children seeking their care in the 2 community health centers compared to our comparison site, we found that in intervention site 1, where we had pretty substantial and significant implementation and adherence to our protocol in the clinic, children in the intervention site, in that first intervention site, had a downward trend in their BMI Z-score compared to the comparison site after controlling for age, sex, and race ethnicity. We did not find an intervention effect in site 2, and I'll come back to some of the reasons for that in another slide. Next slide. In the Healthy Weight Clinic, where all of the children seen in that program had a body mass index substantially greater than the 95th percentile, even though it was open to children with a BMI over the 85th percentile. We also found a significant downward trend in BMI Z-score among children who attended the Healthy Weight Clinic, controlling for age and sex, and a non-significant decrease in percent above the 95th percentile. Next slide. One of the things that we were fortunate to be able to do in CORD is work in real-world settings, and the ability to do that also presents challenges. We were working in two very, very low-income communities and very low resource settings, one of which, and one of our sites, faced substantial institutional challenges that prevented the full implementation of the program. And that led to high levels of attrition in the kind of clinical leadership. During the time of the intervention, the federally qualified community health center relocated to a different facility and lost its accreditation of their family medicine residency program. And those challenges prevented the health center from attaining and attracting pediatric patients. But you know, I say that knowing that that's the reality in many low resource settings, and actually, despite those challenges, there were a number of sustained improvements that were implemented in those sites that we are now that the federally qualified community health center in that community is in better financial condition. They are also just getting back to being able to implement some of the interventions that we got started with in CORD. Next slide. And to conclude, what we found was that Mass CORD's clinical and also WIC interventions, which we'll present in a future webinar, were associated with significant improvements in BMI in one of two intervention communities compared to a comparison site. And that our study, and not just ours, but the ones that you'll hear about today, is one of the few studies and large studies, like all of the CORD projects, that implemented and evaluated community-wide efforts to reduce childhood obesity in low-income settings in the United States. And I'll stop there. Thank you for having me.
Hi, can everybody hear me now? Yes. Okay, great. So this is Sarah Barlow. I am going to be presenting the information from Texas CORD project. Texas was the third site, and appropriately we have the biggest logo. Next slide. This is a schematic of our study design. The outside circle represents the primary prevention strategies, which took place at elementary schools, child care centers, and primary health care, as it did for all the CORD sites. And we had embedded within our catchment areas a secondary prevention that was a more traditional randomized controlled trial where patients from the primary health care offices that we were working with were invited to join the study and be randomized to either an intensive community-based intervention at the YMCA centers or a healthcare-based intervention. And also these are the institutions that were part of some of the institutions that were part of the Texas CORD. Next slide. Oh, that's the, I'm going to focus just on primary health care, and I will tell you that the outcome from the secondary prevention will be discussed at a future webinar for CORD. Next slide. So we identified our catchment areas in Austin and Houston based on census data on household income, education, race, and ethnicity, and you can see an outline of the areas in these two cities. And then within the catchment areas, we identified healthcare offices who had a high proportion of Medicaid and CHIP eligible patients. In Houston, we had 5 offices, and they were all part of a single healthcare organization. 3 of them were designated medical homes, really set up to serve low-income families and children, especially on Medicaid and CHIP. The other two were within our catchment area and had a relatively high proportion of Medicaid and CHIP patients, but did have substantial commercially insured patients as well. In contrast, in Austin, there were 7 offices, and they came from 3 different organizations. Some of them were federally qualified health centers, and the others were nonprofit safety net offices. Next slide. As we were developing the details of our intervention, we spent time talking with the offices that had agreed to participate, and they were all really enthusiastic about the program and about the concept of having support for obesity care. But we did hear about some significant barriers, and an important barrier was the reimbursement issues in Texas. Under Texas Medicaid, a primary diagnosis of obesity is not covered. And so that was really an important issue for the providers in understanding how they could deliver care to the children. As Elsie and Sushi said, these were really active clinics. They were under a lot of pressure to be productive, and so there was concern about the amount of time obesity care would take. And there was some perception that not all families were very concerned about this. And all of that information informed some of what we did and also the training that we did. Next slide. So as Elsie said, we also used the Next Steps material, which was some material that was developed by Dr. Slomberg and Rogers and appropriated ultimately by the American Academy of Pediatrics with help from NISHQ. And the Next Steps material is designed to be used in a primary care setting. It's really a menu of healthy lifestyle themes, such as increasing physical activity, reducing sugar-sweetened beverages, reducing screen time. And that menu is presented in a couple of ways. One is on a poster, as you can see here, that would be in the exam room so that providers and families together could take a look and make some choices about what to focus on at any given visit. Next, click the next advance. So in addition, there is a flip chart. So each of the themes is also presented in on a page of the flip chart that sits on the desk, and you can kind of see that there's some simple graphics and teaching points. And click again. The next piece of this was an activity book that we actually created to supplement the other material. And that activity book has a theme on the top of the page when you open it up, and then some activities that children and families can do at home to try to connect what they've learned from their teaching to what they actually do at home. And we translated all of this material into Spanish, so everything was available in both English and Spanish. Next slide. We also used an electronic health record tool, and if this looks familiar, it's because we got the resources and the process of this from Dr. Taveras based on work that she had done. So we also had an alert when the patient's body mass index was above the 85th percentile, and that alert came up yellow this way and was not actually a hard stop. It offered the option of opening up that smart set, although it didn't require it. And then if the smart set was opened, there was a kind of curated list of diagnoses, orders, referrals, and information. Next click. And then one more click. And within that, embedded in that, providers could easily access some information. So this is an example of a table describing what kind of screening labs, metabolic screening labs should be performed and at what ages, based on weight status as well. And also we identified resources in the community that would support more physical activity and healthier eating, and incorporated that in the EHR. Next slide. So we used the EHR in Houston, but we ended up not using it in Austin. And I think this goes to, the effect of working in real life settings. So as I told you, Austin had 3 different healthcare systems and therefore 3 different electronic health record systems. So it was going to be a challenge. We couldn't just roll out the Epic version that we were using in Houston. And all three of those systems underwent some major administrative changes during the study period. And so despite everybody generally being wanting to do this and being willing to do it, it just didn't happen during the time of our study. So in Austin, we used hard copy material as much as we could. Next slide. For the training, we provided several different training options for the providers. We, including an in-person, we did webinars, and we recorded some webinars so that some of the staff just listened on their own. We provided a shortened version of training and orientation to staff members as well. The content of the training, which lasted about 2 hours, included orientation to the materials, a fair amount of time on Texas Medicaid policy and on obesity visit billing, and how one can make the primary diagnosis for a visit comorbidity if it's present, and make obesity a secondary diagnosis, and also a brief introduction to empathetic patient counseling. We also provided, our training was kind of short, but I and one of our Cord Project staff members made frequent visits, relatively frequent visits to the office to answer questions, to replenish material, just to kind of be a reminder and help providers kind of change their practice habits. Next slide. So we had 12 offices participating, and over the time period of our study, there were 26,000 unique patients. And you can see the breakdown here. The predominant race ethnicity was Hispanic, about 60%, and 20% Black, 20% white. Overall, about 75% were Medicaid or CHIP. And if you looked at all the children above the 85th percentile, it was about 33%. And just as it is nationally, over 5% had severe obesity. Next slide. In terms of the impact, we had a lot of materials, and we don't necessarily have a good way of measuring how often they were used, but we did know that of the nearly 8,000 patients in our age range with BMI above the 85th percentile, 26% were referred to that, to the secondary prevention trial that you'll hear more about in future webinars. And I see that as kind of the floor. We know that providers spoke to those families about weight, and we presume that there were others who also had a discussion about weight that we haven't captured. The trial outcome you'll get at this upcoming webinar. In terms of we did do surveys of the providers at baseline, 12 months and 24 months, and one of the things we looked at was their self-efficacy or confidence in addressing this problem, and we used a questionnaire that Dr. Perrin had developed. And we found that between baseline and 12 months, their confidence in determining whether a child was overweight or obese improved. There, in fact, was no improvement in their confidence in identifying behaviors such as physical activity or sugar-sweetened beverages. But there was improvement, and we were pleased about this, in their confidence in counseling about those behaviors. Next slide. We also did an evaluation of next steps, and we found that by report, providers said that they were likely to use next steps during the obesity-specific visits, less so with the well-child visits, and unlikely to use them with the acute care visits or in children who didn't have overweight or obesity. Next slide. In terms of sustaining the changes, I think I think we've really been able to support the American Academy of Pediatrics in dissemination of next steps in a couple of ways. Because of us, the AAP now has a Spanish translation version of next steps. You can see on the top the next steps flip chart that is available through the AAP shop. We also, there's now also a menu, both in English and Spanish, that can be put up on the exam walls. And finally, the activity book that we had developed in coordination with Next Steps is now available. And that one in particular, because it was developed as part of this grant, will be available to be downloaded for free, so that offices that want to use this will be able to get that. Now, it's not up yet, but I think if people on this call are interested, we can get them copies. In Houston, I think we laid the foundation for a healthcare community partnership between the Houston offices and the new YMCA Healthy Weight in Your Child program. And I think we don't really know at this point, partly because I've left Houston, whether there's been ongoing use of these EHR tools and Next Steps. Next slide. Oh, that's the activity book. And next slide. So lessons learned, I think we learned some of the same things that the other CORD projects learned. These EHR reports can be so helpful. The modifications and reports are really, really important, but they're not easy. They're not as easy as they seem. It takes a lot of resources and institutional commitment. So I think this is an area that I hope we can together, form some advocacy around. The billing issues in Texas were an important issue. We discovered a layer of coding review between the provider insurance that we needed to address. And finally, we saw a large variation. We had 12 offices we were working with, a large variation in the office uptake between those offices that were highly engaged and those that were much more passive. And I think that this is an opportunity for further exploration, to understand what it is about those highly engaged offices that we can learn from and pass on to the more passive offices, because the referral rate ranged from less than 10% to over 2/3. Next slide. And that's it. Thank you.
So thank you, everyone. Great presentations. This is Deanna Hellshire again, and there is the contact information. We do have time for a few questions, so we're going to be checking that out. But while we're looking at that, I'd like to tell you that the webinar is archived with the slides at msdcenter.org. So we have a question from Glenn Snyder. Would love to hear more about the provider collaborative. We too have run 2 provider collaboratives with the AAP Maryland. Thanks. So Elsie, I think he's referring to that you spoke about.
Yes, so we've worked very closely with NICHQ, the National Initiative for Child Healthcare Quality, who has years of experience running these different collaboratives. In our case, for obesity, they have an infant mortality collaborative and other similar efforts for other conditions. And it worked very well. We're actually very interested in thinking about a broader dissemination, not just of CORD, but as Sarah mentioned, how do we support other practices that are interested and really are looking for ways to include some of these tools into their electronic health record and within their primary care setting. We'd love to do that with NICHQ because of their experience with this, but they've been the primary group that we've worked with, and there's also interest and capacity that they are developing and have been working with now for a number of years on virtual learning collaboratives. So I would encourage you all to look for some of those resources and those opportunities through NICHQ in particular.
Well, Elsie, while we have you on the line, we have another question. Can we get more details about the EMR templates you've developed for Epic and others? Can they be shared?
Yeah, so I think we've noticed, and what's coming up in the questions is we now have a number of different studies, the 3 presented today included, where we're developing these tools, and really kind of a lack of access to these tools that have already been developed. And actually, it's one of the things that we've talked to CDC about and Dr. Blank, and we'd love to make those available. We have them that we send out to individual clinicians, but it makes me think that, and I'm sure Sarah and Heidi would agree, that we need a central resource to serve as kind of an inventory for these tools. Ours are, we've developed many of them for Epic, but we have a number of different tools for NextGen and for eClinicalWorks. But I think that's the next place that we need to go, is having a central repository of these screenshots or other kind of how-tos for others that want to implement these tools in their own records.
Great. Thank you, Elsie. The next question is for Sarah. So interesting to hear about different implementation models. In Texas, where the practitioners had the option of ignoring or clicking on the yellow alert box, were you able to track how many opted to follow the prompt?
No, I don't really have that information, which would be useful, and probably future studies can work with that. I did want to add to what Elsie was saying at the last question. At least for the Epic, the changes that were made are really tools that are part of Epic. Those changes, can be made and adapted if you have a model without necessarily needing to go back to the main Epic, software.
Yeah. I think that's something really that we need to examine more closely in the future. So it'll be interesting to look at other studies and see how we can get more of this into practice. So, Dr. Ayala, I have a question for you. With the family wellness program, I know y'all did a lot of different activities with that program. So one of your recommendations or lessons learned was there was more efforts to get specialty care in rural communities. So did you think that the family wellness program kind of met that need, or did you think that you needed additional wellness expertise outside of that?
That's a great question. We feel that community health workers who were implementing the family wellness program were very well trained, but they don't necessarily have the training in dietary assessment and nutrition counseling that, say, a registered dietitian would have. And so we feel that it would be a much better program to have that complementary service available. So I think it's important to be able to have contact with a professional that has in-depth knowledge, and then the community health worker being able to facilitate the utilization of those knowledge and skills in everyday life. Unfortunately, we just were not able to follow through on that plan given the lack of resources in the community.
Great. Thanks for sharing that with us. So it's time. We want to thank everyone for joining us. Again, the PDF and the archive of today's webinar is going to be posted to msdcenter.org. This is the first in a series of webinars, so we will be sending further information about them. They will be covering several of the different intervention components or the areas in which we focused on, so including early childhood interventions, school projects, secondary prevention, and then some overall results. So we hope that you'll join us in these upcoming webinars sponsored by the Michael and Susan Dell Center for Healthy Living at UT Health School of Public Health. Good afternoon. Have a great rest of the day. Bye.